Good afternoon, and welcome to FCI's webinar series. I'm Samira Salem, the Director for Social Innovation and Community Development, and we're really pleased to have you with us here today. With the help of BMO Harris, we're able to offer this series of webinars, and we'd like to express our gratitude to BMO Harris for being an active partner in Wisconsin communities. As always, we welcome your questions and comments throughout the webinar. Please feel free to type your questions and comments in the chat box on your screen and submit them to us throughout the webinar. We'll save some time towards the end, and we will be sharing those with our guests today. So, as I said, throughout, please feel free to use it. In addition, we are going to be recording this webinar as we always do, and we are going to make a link available to you afterwards in case you'd like to share it with any of your colleagues and friends. So we're honored to welcome the esteemed Dr. Renee Kennedy, the Chief Executive Officer at the Michigan Public Health Institute. Dr. Kennedy is a nationally recognized thought leader in health disparities and inequities, cultural competence, and social justice. Dr. Kennedy's public health career reflects her long-standing commitment to address racism and promote health equity and wellness through research and health promotion interventions. Prior to the Michigan Public Health Institute, Dr. Kennedy was the Ingham County Health Department, the state's first public entity, local health department, and federally qualified health center, where she served as the appointed health officer there. She's also an assistant professor at Michigan State University's College of Human Medicine's Program for Public Health. Dr. Kennedy will be talking to us today about important issues at the intersection of racial equity, health equity, wellness, social justice, and community development. The importance of this topic cannot be underestimated, and we're very fortunate to have her with us to share her expertise. Welcome, Dr. Kennedy.
Thank you very much. I am completely excited about the timing of this topic. Certainly the urgency that we're experiencing in our country, and being able to broaden the dialogue with you and to partner with you in this regard. So we'll look forward to getting started. So I'm going to just talk, and I'll trust that you will follow me. And I'm sorry about my technical confusion on that part.
No worries, no worries.
I want to just start out acknowledging you guys, and I have a quote that I came across in a leadership book, and I talked to my team and my colleagues about bringing their whole self to work and to this mission-driven assignments that we have in our lives. It's not like some other jobs that are not driven by mission. And so just sort of an ode to you. It says, to all the men and women who go to work each day and bring their humanity with them. They make a contribution to their organization by doing what they do, and they make a contribution to the world by being who they are while they do it. It is really going to be incumbent upon us to sort of get that revelation, to have the drive and the passion to change the barriers, the racial inequities that are impeding our own health and our own wellness in the society. And so you have probably saw some objectives as we were advertising on what we were going to talk about. If I were to give you the Cliff Notes version of that today, I would say I want to just kind of agitate your thinking a bit, give you maybe some framing to build your courage to initiate these dialogues, not simple conversations, but powerful, action-driven dialogues that will help us advance the concerns around racial justice and equity in our society, and certainly using my context of health. So if you think about health or community in which we do our work, right? If we think about community in the context of what creates health, and I like to say that I pretty much, as a health officer, wanted to deputize everybody. You're all health professionals because we see health very, very broadly. The World Health Organization defined health as this complete state of well-being, right? Physical, mental, social well-being, not just the absence of disease or infirmity. Health is not really just a clinical or a medical construct. It is a social and a comprehensive construct. And so if we think about community in that light, I want us to click through a couple of contrasting pictures. So the first picture sort of has what I like to call the 4 basic food groups of how you stay healthy, right? This is what we get in the classic clinical and medical literature. Be sure that you're eating your fruits and vegetables. Be sure you're getting plenty of exercise. Sleep is now getting lots of attention, right, in the media, sleep deprivation, and make sure you're sleeping well, and don't forget your regular checkups. Well, if it were that simple, health access issues notwithstanding, we as a nation would be much healthier than we are. And what we realize is that those 4 things have a lot of other factors in community working against them. So for example, on the next slide, we see that health is really determined by what does your walk home from school look like? What does the walk home for your children look like? Is it beautiful and green, or is it tattered with all types of threats, both vehicles and other pollutants as you walk back to school? We know that health is also impacted by what your business district looks like. So you'll see on one hand a boarded up, pretty dilapidated business district, and at the bottom a very vibrant downtown grocery with probably locally sourced food options. We know that health is impacted by infrastructure. So you can see, and we're certainly sensitized, as you see on the next slide, to challenges around water and infrastructure. I almost picked a picture to exaggerate those needs, but we also know that you have abandoned homes where people live, right? So what is that context of infrastructure in homes, indoor air quality? How does that affect community in the context of what creates health? And we also know that if we look out our backyard on our next slide, that the view from your backyard impacts our health and well-being. Are you looking at pollutants going up into the outdoor air quality, or do you have greenery? Do you have a lovely bird feeder where you can get refreshed by nature, and on and on and on? This next slide is really striking for me because it talks about even the built environment, right? So this is at the top a picture of an LED certified, a LEED certified school, right? Progressive, modern. The bottom is a picture of another school that is built next door to a county jail. And I would dare you, if you were a betting person, to figure out which one of these buildings is the school and which one is the jail. They're almost, you can't almost detect the difference. Those were built environment decisions that were made. So as we think about what creates health and what creates community, I challenge us with another quote. You're going to find that I love quotes. This one by Martin Luther King, and I think that audacity is now like on my favorite list of words, but he says, I have the audacity to believe that peoples everywhere can have 3 meals a day for their bodies, education and culture for their minds, dignity, equality, and freedom for their spirits. In the midst of everything bad happening around him, he said, I'm just going to dare to believe that we can get this right. And I would submit that in the midst of all types of difficulties happening around us right now, right, that I have the audacity to believe that we're going to be able to get that right. And so that shifts us from thinking about community in the context of what creates health and more about community in the context of what creates equity. So if you'll click another couple of slides for me, Tom, we'll move right on into this context of equity. And I want to introduce a couple of vocabulary terms for you. We believe in advancing dialogue as a methodology, right? This is how we do things. A lot of people will say, well, when are we going to stop talking about this? The problem is we are talking and not really acting. We can't act effectively until we have effective discourse. And so what is the goal? Certainly these two things that I want you to think about. One, definition, and if you Google these terms, there are tons of them out there. These were ones that our community decided were best for where we were, what the priorities were, what the needs were. And so you'll have to do that as well in your community. It is not one size fits all work, right? So we really liked Margaret Whitehead's definition. And I particularly like her definition because she sort of goes beyond things, right? So she's saying inequity, and we almost can parenthetically use the word health in that definition, but it is about differences in populations, and you see I've done that parentheses, population status or population health status and mortality rates that are, these are the buzzwords, they're systemic, they're patterned, they are unfair and unjust. I love that she introduced values into the dialogue. And she says there's something we can do about it. So when you hear colleagues sitting around saying, well, we can't fix racism, well, we can't change poverty, hogwash, right? We can, and we have in the past. And so that's the push. And it's about those things as opposed to simply assuming that this is random or it's just caused by those poor people who just won't eat better, right? Blaming the victim, as it were. So this definition for us really began to channel authentic dialogue. Certainly the goal is health equity. That's a tough one to define. I really love a recent publication by Paula Braverman with funding by the Robert Wood Johnson Foundation. And they particularly looked at how do we define health equity in contrast to sort of health disparities or some of the other terms that are out there. And Dr. Braverman really frames this as health equity is the moral drive that pushes us to address disparities. So in your world, you deal with funding disparities, right? There are some entities that some systems would simply say are too large of a funding risk. That's an inequity, right? That's a disparity, a difference across sectors. But what is that moral commitment, just as Margaret Whitehead introduced values, what is that thing that's going to drive us to battle health disparities, to battle social and economic disparities, and not simply to measure them and admire them, right? So those things, we often, we're challenging ourselves to say, okay, people keep talking about a health equity lens. Oh, well, if we look at this through a health equity lens. And we just said, well, what does that mean, right? So if we take those two definitions, the one I just showed you, and a definition of social justice, which is kind of that absence of unfair advantage across race, across class, and across gender, or really any form of difference, if we looked at those definitions and we said that we're using a health equity lens, then what would that mean for us? And so we decided that if we were doing our work through an equity lens, it would mean that we were actively seeking out what's unfair, not just to describe it, not just to admire it, but to reverse it or to avoid it. To say, okay, we are intentionally looking for this. We're not going to make that decision because it's going to result in this unanticipated negative consequence. So to reverse it or to avoid it. We decided if we were using an equity lens that we would be aspiring to apply justice in serving individuals, in serving families, in your case, in serving communities, which is, right, a collection of families or areas. We decided that an equity lens meant that we would recognize that there's an impact that social resources have on the care and on the behavior of individuals and the families. It's not just about get them to the doctor's appointment, give them a taxi voucher. It is about what happens when they go back into their neighborhood, back into their family, and what are those social resources that are either benefiting or deleterious to their health goals. And lastly, we decided that if we were using an equity lens, that we would have the responsibility for identifying and facilitating those social opportunities for individuals and families to readily and to easily attain well-being. I like to say that the choices people have are determined by the choices people make are determined by the choices people have. And the easy choice is, the healthy choice is not always the easy choice. I was at an airport recently and trying to do well, and you look at the menu and there's a vegetable little box with broccoli and carrots and some dip, and then on the other side of the menu there's French fries. Well, you can probably guess, if I was with you, I'd say, how much do you think the broccoli and cauliflower cost? Well, I'll tell you, it was $12.99 for a very small box. The French fries, on the other hand, $4.99. The healthy choice is not always the easy choice or the accessible choice. So this is the challenge that we face. So I want to do a polling question at this point, because I want you to think about this issue of equity as a value and a social right. Now, these are questions that are a part of our dialogue-based organizational assessment. And we're in the process of formatting that and making it beautiful, and looking forward to distributing that through our website as a resource to you. But I just pulled a few of those questions. So again, this is a dialogue tool. So you guys do this quick poll with me, and when you're thinking about your organization and this term, this phrase, equity is expressed as a value in your organization, and the entire department strives to meet goals related to eliminating the root causes of health inequity. Would you agree, strongly agree, would you disagree, or would you strongly disagree that that is the case in your organization?
Great. So we're seeing the results from the polling question coming in right now. We'll give folks another 10 seconds to respond to this. So as of right now, we have 23% strongly disagree, 15% disagree, 46% agree, and 15% strongly agree.
Great. Interesting variation, right? So again, we are about dialogue, so there's no right or wrong answer. And when you do this with your teams, it's always intriguing to have them see the variation of response across the same staff. It's like, okay, well, why do you help us understand why you agree so strongly with that? And here's my lived experience. So this is, again, about beginning that dialogue. So we have some vocabulary that we can use in dialogue. We have this lens, and the challenge becomes, where do we focus? Certainly yesterday, many of us were focusing on the solar eclipse. But now, as we think about this work, where do we focus our attention? So the challenge is seeing believing, right? So we can be looking at the same thing in our society and seeing it completely differently. Optical illusions are all around us, particularly in this current political and social climate. As you look at various news outlets reporting, they are representing the precise event completely contradictorily, right, in some ways. And so what is it that we're seeing? Are we seeing an old hag? Hopefully you guys have seen these before. Are you seeing an old hag, or are you seeing a young woman? Are you seeing a forward view of a Black man, or are you seeing his profile? These subtleties are what really contribute to this new discourse around implicit bias. And the challenge becomes that not only is race a social construct, right? We know from the Human Genome Project that there is greater variation within race than across race, meaning that I have the statistical likelihood to be genetically more similar to someone who checks a different box than I do with someone who checks my same box. So we know that race is not a biological construct, it's a social construct. And racism and the racialization that results from that construct are also socialized. So we're taught to live race a particular way, experience race a particular way, both direct lessons and indirect lessons. And ultimately, that impacts our subconscious and unconscious thinking. There are, if you've not ever done an implicit bias test, I encourage you to do so. There's an online one, the IAT. If you search implicit bias test, Harvard University, it will come up. It's an online test. Really enlightening, because you don't know what you don't know. And until we become intentional about this, we'll continue to hear people say things like, well, I'm not a racist. Author Eduardo Bonilla Silva has a book, Racism Without Racist, because no one's intending, well, I'll submit that the majority of people are not intending to be racist, but there are racialized consequences of many of their actions. So what do we do then, right? I love leadership work and pushing leaders. I get pretty frustrated these days with what I call cowardly leaders, and I'm trying to push people to be more courageous, not just in a hierarchical leadership position, but we are all leaders. We all have spheres of influence, whether it's in our neighborhood, in our community, in our family, on our job, across our peers. What should we be doing? And these were two things that Howard Koh, who was at Harvard University, did research on public health leaders. And he found that public health leaders are an interesting breed. And I would submit that CDFI leaders are also an interesting breed. So he said that we're generally driven by a profound and a fundamental sense of mission. Like, why are we doing this? The so what of this, right? What is motivating us? And he said that there's something in that sense of purpose that motivates public health leaders and leaders like yourself to leave the comfort of the sideline and to wade into controversy. If we are going to reverse the continuing hideous consequences of racism and the history of othering and disadvantaging people in this country, we're going to have to be comfortable with controversy, right? People are not going to always agree with us. People didn't always agree with Martin Luther King or those who fought with him. But it's time for us to step up and say, there is a need for change, and I'm going to be a part of that change, right? Mahatma Gandhi. So let's think about leadership and do another polling question if we could. This question is, leaders explicitly, again, thinking about your organization, leaders explicitly use health equity and the social determinants of health as criterion in determining policy, positions, allocations of workforce, and budget decisions in your organization. Would you strongly disagree with that? Would you disagree? Would you agree? Or would you strongly agree?
Great. We're seeing the results kind of trickling in right now. We'll give some folks a little bit more time to come in about 5 seconds. So currently right now, 18% strongly disagree, 27% disagree, 27% agree, and 27% strongly agree.
So I hope that those of you that are on the agree and the strongly agree end of this poll are feeling emboldened by this, right? So to stay where we are when we're in a good place and to advance where we are to a better place requires intentionality. And I hope at the other end that it is equally motivating to say, well, what do we need to do differently? Or what do we need to start doing? One thing that is very, very clear, and we have said in our work, that we have to talk about racism explicitly. And we tend to do our work around sort of the paradigm of race, class, and gender oppression. But we believe that in many ways, we're good at classism and sexism because we learned how to do racism so well, right? Just the historical passage of who we are as a nation. So I want to share with you 2 arguments and a challenge, right? So in our work, we have found that race, class, and gender oppression in their sort of modern forms, they are subtle, but they are pervasive and they are insidious. The challenge is that each time they're identified now, that unearned privilege asserts itself and sort of diminishes them. No, 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 no. So we see that diminishing concern occurring in sort of 3 ways. One, we just explain it away. Well, I know racism exists, but, or you're just being hypersensitive. Well, you know, or this whole issue of the fairness paradox, that we are in this society socialized that fairness means sameness. So if we were to treat a particular group differently, we would be all in arms and say, that's not fair. I mean, we see disparate treatment all the time. I mean, those of you that have children that might have a teenager and then might have an elementary school child. You don't let your elementary school child drive the car. Why? Because they're not old enough. They don't have the skills. They don't have the needs. But somehow or another, in this work around health and well-being, we have this perception that everyone has to be treated the same or it's not fair. Sometimes the most unfair thing we can do is to treat people the same. And the other way we see this this diminishing concern come is sort of this benign neglect. Well, you know, we try to do things for these needy populations, but they just don't show up. Or, you know, at work, we use this term fit, just wasn't a good fit. And so all of these things we have to trigger our attention to, fight against the implicit bias that would make us see these and say, oh yeah, that makes sense, and push against the prick of that. The second argument is that when we, in order to undo our business as usual, that we have to actively create a culture where we welcome challenges to privilege, challenges to oppression, that people are comfortable being the, excuse me, but that person, right? And that it's not always the brown person that is the hand raiser. It is all of us when we see it. And what would that look like? So at the personal level, and we tend to do our work across these structures or these levels, it would really be kind of doing our own work. You may have heard that phrase before, but where am I demonstrating implicit bias? Where those biases come from? How does classism come into the way I interact with the communities we're trying to serve? So maybe I better take that IAT test. At the interpersonal level, we would invite challenging analysis of interactions when something is sort of sprinkled with racism and sexism. At the institutional level, we would automatically ask about consequences of privilege on any policy that we would be creating. It's sort of that, that lens that I was talking about. And at the cultural level, we would start trying to create a new normal for our community by openly challenging oppression, by actively working to eliminate racism, really at its root cause. We like to, in this society, pretend like we did this work already. We had the civil rights movement and it's all done. Well, what these past several months have shown us very specifically is that we've not done the work well. And there is a lot of unresolved consequences of our legacy of racism and oppression, gender oppression, even class oppression, that we are obligated, I would say, to deal with. So those are the 2 arguments. So the challenge given those arguments for us is that in order to tackle racism, classism, sexism, and you know that classism is conflated with racism, right? And sexism is conflated with racism. Black women tend to do worse. So it's one sort of knotted up web. But we've got to figure out a way that we can have this dialogue in a way that is tolerable, I'll say, for people who experience oppression every day, and to people who have no awareness that such oppression occurs. We have to do the work in a way that, one, keeps people whole, and two, that keeps people at the table, right? Because they don't have to have this conversation. I was in a workshop just this last week, and a couple of people of color were like, I'm not trying to help white folk get this anymore. I'm tired of retelling my story. So when we use this term, non-target group members, meaning those people of privilege who haven't historically experienced oppression, that oftentimes when they are made aware of oppression from a target group, they want to gain immunity from it. Well, I didn't own slaves. Or, well, I don't have a Confederate flag on my truck. And if they don't get that immunity, then that discomfort will oftentimes push people to leave the conversation. On the other hand, people that have experienced oppression and racism really see the dialogue as both painful. I've got to unpack this one more time, pick at this scab just as it's healing, and also pointless because they've told the story over and over again, and those in power and those with privilege don't seem to grasp the truth of their experience. So in their case, they don't remain whole, and they just will abstain, or people that experience things. And I like to say, for me, even depending on what side of the bed I got up on, am I going to push through this one more time, or am I going to just say, not going to do it? I had the privilege of speaking at the Wisconsin Public Health Association conference a few months ago, and had a couple of interactions with colleagues during Q&A where I had to make a conscious decision. Am I going to be authentic and really try to stretch this person that's having this challenging conversation with me, or I'm going to pretty much just shut down and say, don't have the strength today? That's the challenge, to stay at the table, to be willing to feel it one more time so that we can, as a society, advance together. So how do we then embrace community? And I want to just give you a slightly different paradigm of community, and how do we not just incorporate health equity, but how do we apply health equity? A lot of times when we're talking about equity work, a lot of people will say, you know, we would, but we just don't have time. I don't have a staff person that I can dedicate to this. And we would submit that equity work is not what you do. It's not one more thing on your to-do list. It's how you do everything that you do if you are a part of a mission-driven organization. So a couple of things for you guys to think about in terms of community. I like to frame it as sort of the conundrum of community. And that ode to thee quote that I started out with, I want to remind you that you are a part of community. So neighborhoods, we know, David Williams, who's a Harvard researcher, has published a lot on how neighborhoods now become a mechanism for racism and the operation of racism. So whether we're seeing sort of elective or selective segregation, people are being forced into particular neighborhoods because they don't have fiscally reasonable other options for themselves. Or people are preferring to be in a space that they think is safe and where they'll see people that look like them, this challenge. But what we know is that neighborhoods and communities are structured class hierarchies. We don't have many multi-level homes, multi-economically driven homes and neighborhoods. Increasingly, we're beginning to see that. But the vast majority, most neighborhoods are class hierarchies. And with that, you see different tax bases, which are then ascribed to school resources, and the consequences of the model and the policies with which we've structured the lived experience in this nation, again, has negative consequences for many varying people groups. So we begin to see these unanticipated consequences like community as othering. That's why I'm reminding you that you are part of community. It's not just, oh, what are we going to do for them? Or how are we going to help fix that problem in that community? You know, communities are beginning to say, stop doing to us and start doing with us. We don't even want you to do for us. This is a partnership. One of my colleagues at the University of Maryland, who's a community-based researcher, said that his community said, no decisions about us without us. We're at the table. So how do we take that conundrum and affirm sort of this crowd source of people that you'll see on the next slide, where people are also tired of being problematized? When I was a researcher, a full-time researcher and faculty at Michigan State University, I did work on infant mortality with African-American moms, having been an African-American mom that experienced the death of my firstborn son due to prematurity. But when I came out to share the findings, which of course are negative, the community said to me, you know, you're bad as the rest of the researchers. You guys just come out here and tell us what we're doing wrong constantly. Was that my intent? Absolutely not. So how do we stop bringing bad news to communities, and how do we begin reframing that image of this crowd of community where we see community as resilience? I said if I stayed at the university, I was going to stop studying why were so many Black babies dying and start studying how are any Black babies surviving in these very high-risk, marginalized communities. And what if we say to moms, how about try this? This worked for this mom, instead of saying, don't do that, that's bad for your baby. How do we see community as solidarity? And how do we see community as power and a sense of collective power? So let's do another polling question, and then we're going to see if we have time to click through a couple of things around power. I might need to skip through those, but you guys will have access to them when you have access to the slides. So working with communities, the polling question is, your organization routinely considers ways to involve marginalized groups in setting priorities or in conducting research, meaning whether it's a needs research, whether it's empirical research. Your organization, you would say, is doing some authentic involving of the people affected, doing with them as opposed to doing for them or doing to them. Strongly disagree, agree, and strongly agree.
Thank you, Dr. Kennedy. So we're seeing the results come in right now. 14% strongly disagree, 29% disagree, 50% agree, and about 7% strongly agree.
Yeah, sort of my suspicion. So we're going to hit, I put two polling questions around community because I really want you thinking deeply about it. So let's just bounce right to that second question, which is more framed around working with communities. So the question being, the organization, my organization, works with neighborhood and community groups, but doesn't assist them in mobilizing for action. We'll do this. We'll give you this resource, but we don't really want to be a part of it, and you guys do your thing based upon the funding that we provide. So what does that partnership look like working with community? Do you strongly disagree, agree, or strongly agree? Works with groups, but doesn't assist them in mobilizing for action.
So we have 6% strongly disagree, 44% disagree, 47% agree, and 0% strongly agree.
All right, I feel like we got some marching orders from those two. So we talked about the conundrum of community. Let's talk for a second about the opportunity of community. I mean, you guys have that word, right, in your field. CDCs, CDFIs, you are about community. But I would challenge you to think about community maybe from a couple of different paradigms. That community is defined more by relationship than by radius. I have members of my church, although we like to consider ourselves a community church, some people commute an hour to come to our church because it's not about that radius. It is about the relationships that they have. Community, I would submit, is also defined more by the values of the people in relationship than by the locale, right? What are the values that we share? What are the truths that we hold collectively? And that community is more defined by the affinities than by the vicinities. What are the shared experiences? What are the things that we're like-minded about, and not just about location? And so how do we take ourselves somewhat out of the geography of community? And I know that can be challenging because even in public health, we have census tracts and we have counties as governance structures. We've built in geography to the way we think about community, and that in and of itself can be a barrier to how we serve community. So what is the narrative that we're weaving, and how do we begin to change that narrative? I like to challenge people to start questioning the questions. We just may be asking the wrong questions. There's that old slapstick joke that says, have you stopped beating your wife? It's a yes or no question, but neither one of those answers, right, sets you up for a good response. So these questions come from some work we've done with our colleague, Dr. Richard Hofrichter at the National Association of City and County Health Officials. And so you'll see these two options. I won't go through all of them. But for example, the standard question is that option A, and say, what interventions can address health disparities? Well, really the question that we should be asking is what generates health inequities in the first place? Why are we dealing with these downstream consequences, the health disparities, and what can we do upstream to keep those disparities from happening? How can individuals protect themselves against health problems? Well, the actual question, the better question may be what kind of collective action is necessary to confront health inequities? It's not just about access to clinics. Matter of fact, you probably are familiar with the Federally Qualified Health Center network. The very existence of FQHCs is the result of a direct action of communities on government to say, we want more, we need more, we want communities that are available, that we sit on their boards, that we help advise and structure the services that are being provided. And it was an effective consequence of a direct action. How do we treat the consequences of health inequity? Perhaps the question should also be, how do we act on root causes of inequality? What again is that upstream? And in public health, we have this quality improvement model called the 5 whys. And we just keep asking why. Well, why is he sick? Well, because he couldn't get his medicine. Why couldn't he get his medicine? Well, because he didn't have resources. Why didn't he have resources? And that gets us to the root cause. So I'm actually going to skip through, Tom, the next 3 slides because I want us to just kind of land and have space for some questions. I want you to think about power. Let me just throw that out as you click to the next slides and just land at the Martin Luther King quote for me again, Tom, right there. Because this is about power. It is about the ability of communities to affect change that they need and that they desire. So Martin Luther King, the beauty of that audacity quote is that it ends with, he has the audacity to believe that because he believes that what self-centered men and women tore down, that men and women who are other-centered can build up. I would submit that you, as a mission-driven, controversy-seeking leader in your organization, are those other-centered men and women. How do we allow ourselves to build alliances and coalitions? We're going to skip the next polling question as well and land on sort of 4 points for you to think about in closing. That as you advance dialogue that's going to be intentional about battling the continuing legacy of racism, let me give you, look at my terrible animations. Let's just click through all of those, Tom, and get them all up there. We like to deal with one construct that we call intent versus impact. Nobody, again, I'll say that, certainly there might be some, but most of us are not intending to be racist. But it is we're obligated to deal with the impact of our actions. If I walk by someone and kick them in the shin, I didn't mean to hurt them. That was an accident, but I still should be responsible for getting a cold towel, getting a chair. So this tension of impact versus intent. Both and thinking. We are socialized again in this nation, given our history, that it's either or. It's either this or it's that. We're very dichotomous. And in dialogue, we try to reconcile truth and say, yes, it is that, and it is this. That brings us to a richer dialogue that drives solutions. Unconscious versus implicit bias. Again, it does not matter that we didn't know. You know, there are those people that don't get it and don't get that they don't get it. We're trying to agitate people to recognize that each of us, because we are products of this environment, have biases that we've got to unpack so that we can be a part of a solution. And the other challenge to having authentic dialogue across race is that people of privilege tend to see racist events as incidental. Well, that was that incident. Yes, that happened. People that live their lives in a racialized way, people of color, tend to see racial incidents, racist incidents contextually. This is one more time that this has happened to me or to someone that I know and love. So institutional racism continues to manifest. It is baked in to most of our structures, and I hope that you're beginning to see some of that based upon our conversation today. Let me close with just a couple of quotes. Again, we're not going to have time for our last two polling questions. We were looking at around policy development and analysis and being a little more strategic. But let me just close with actually my last quote. Let's skip this one. I'll just say that the Renee Kennedy version says, we can't get tired of doing the right thing because I believe eventually we'll reap. My children will reap, your children will reap. This is generational work if we don't faint, if we don't throw in the towel. I love this quote by Antoine de Saint-Exupéry. He says, if you want to build a ship, don't drum up people to collect wood and don't assign them tasks and work. Don't tell them what to do, but rather teach them to long for the endless immensity of the sea. Equity and justice are that endless immensity of the sea. And if you're in a dialogue and somebody says, I don't want to talk about those social justice warriors, because there's all kind of trigger language, abrogate the terms and get to the meaning and the heart of what we're trying to change together, regardless of political persuasion and regardless of cultural and ethnic background. Together, we can make a difference. We can apply justice and make sure that we are the nation that we were intended to be when our historians first established us. So, wow, 6 minutes, Samara. I'm way over a time for questions, but if there's anything that popped up that I can kind of address, happy to do that in our closing minutes.
Great. Thank you so much. A lot of food for thought. I mean, tremendous topic, which I think, you know, this is something that we could continue going on. So thank you so much for just giving us a glimpse into, I think, not only the looking at health equity, but how it intersects with all of these other things like social justice, like racial equity, and community development.
Yes.
So this was great. One of the things that struck me was, and it struck me because we just had a conversation yesterday here at FCI, and it echoed what you said today, or maybe previewed what you said today about people of color and the challenge of keeping them in the conversation.
Mm-hmm.
Right? Being tired of educating allies, and how can you do that in a way? What needs to be done to ensure that these voices are in the conversation, and yet understanding that there's almost this extra burden that's placed upon them. So I know you kind of gave us some hints, but if you could maybe dwell a little bit more on this and the challenges around it, because I think it's very real.
Yeah, I think that white Americans have to be a part of doing their work, and their work is not to understand what it's like to be Black or to be Latino or to be Asian American. Their work is to understand what it's like to be white in America. And so I think that as each of us shares the load, it's easier to have the dialogue. Now, people I talked about getting up on which side of the bed. Respecting where people are at any given time in the dialogue, I think is important for advancing the dialogue. In public health, we talk about herd immunity around immunizations, that we just need to get enough people immunized so that there aren't enough sources for a vector to pass. So it's sort of that critical mass theory. Are there enough of us willing to have the uncomfortable discourse? And we like to talk about increasing your comfort with discomfort. But the more you have the conversation, the more comfortable it becomes. But yes, today may not be the day for your coworker to have that conversation, but tomorrow may be. So it's just, I think, a vigilance and a focus to continue adding, so that not just we're just continuing to have comfortable conversations, but that we're advancing dialogue that will bring change.
Great, thank you. And I'd like to encourage our audience to please, you've got a couple of minutes, take advantage. If you have any questions, please go ahead and send them in. We're monitoring the chat and the question boxes. But in the meantime, I just wanted to point out, from my perspective, that the whole idea of reframing, I think is incredibly powerful. And we have to remind ourselves to do this, because it's easy to fall back on our sort of old ways of thinking, which really don't help to advance equity, health equity, racial equity, but thinking about how do we reframe these questions. And so I really appreciate that one particular slide, which gives us some clues as to how we might go about doing this. The idea of community of solidarity and collective power, I think those are pretty powerful ways of thinking about community. It's not necessarily one that we're taught. So I appreciate those concepts.
I'll add one more quick thing, Samir. I think we again are socialized to kind of avoid difference. Like even in teenagers, I mean, people want to wear the current jeans and the current shoes because somehow or another difference makes us uncomfortable. Difference in dialogue is what brings richness to dialogue. And being able to listen deeply and not be thinking about what am I going to say, what's my retort, but thinking deeply to learn through difference. And in this nation, difference is oftentimes lived across race, right? But to get ourselves in a place where we hear, we can learn, we can know, and then do differently.
I love it. Thank you. So we're not seeing any additional questions come through. We're pretty much at our time. Again, I want to thank you so much for this thought-provoking conversation. Thanks to all of you who listened in today. Thank you for your time. I want to remind everyone that there's going to be recording available for playback from our website that will include the slides. I've been asked by a couple of people for your slides, so those will be there. Also, I just wanted to highlight that our next webinar will be with Kathy Kramer. She's the director of the Morgridge Center for Public Service and a professor at the Department of Political Science. She is going to be kicking off a new series that will be starting up in the fall, From Alienation to Allies, Finding Common Ground Across Rural and Urban Wisconsin. So she will be doing that September 25th, 12 p.m. Stay tuned for more details, and we'll be sending out registration information. Thanks again, Dr. Kennedy, and everyone, have a great day.